Thank you for joining us today, no matter when or how you're tuning in. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for December 2016. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Public Health Grand Rounds website for more details. Some of today's presenters are lawyers, but they are not your lawyers, nor are they the agency's lawyers. If you need legal advice or counsel on anything presented today, please seek an advice of an attorney licensed in your jurisdiction, but please watch the session first. Grand Rounds is available on all your favorite web and social media sites. We are also live tweeting today. Use hashtag CDC Grand Rounds. We have a featured video segment on YouTube and our website called Beyond the Data, which is posted shortly after the session. This month's segments feature my interviews with both Dr. Karen DeSalvo and Mr. Matthew Penn. We've also partnered with the CDC Library to feature scientific articles relevant to the session available at the CDC Library website. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. In addition to our outstanding featured speakers today, I'd also like to acknowledge the important contributions of the individuals listed here. Thank you. We'll now hear some taped remarks from the CDC Director, Dr. Thomas Frieden.
Law is one of the many important tools we can use to protect the public's health and safety. Law touches every aspect of our day-to-day lives, from the seat belt you used on your way to work, to the clean air you breathe, to the water you use to make your food. Laws are in place to protect your health and safety when suggestions or education aren't enough. In the early 2000s, some of the most effective public health laws related to restricting tobacco use were scaled up in New York City. When the public health community saw how well these laws worked to decrease smoking and improve health, they became templates for public health action around the country and throughout the world. Some of the great public health success stories of history, childhood immunization, safer workplaces, clean water, wouldn't have been possible without changes in laws and policies. In fact, federal, state, tribal, local, and territorial jurisdictions routinely use law to make individuals' default decisions healthier and to protect us from threats that we can't individually control. Examples of laws currently in place or being adopted to create healthier contexts include prohibiting the sale of alcohol to minors, ensuring fluoridated water to protect oral health, increasing prices of unhealthy products such as tobacco, alcohol, and sugar-sweetened beverages, and protecting the health of children by banning the use of lead-based paint. This year, as the Zika epidemic grew, CDC's public health lawyers helped Puerto Rico's legislators create a vector control unit. We advised them on what makes an effective and efficient control unit from a legal standpoint, based on the best practices from around the United States. Law and public health are inextricably linked because law is a key function to leverage better, faster, and longer-lasting public health outcomes. Legal interventions aren't usually our first choice, but they can be very powerful, especially in combination with more traditional public health action. Because of our mission to protect our nation by rapidly and effectively responding to health threats, CDC has a unique perspective on public health law. We use it to research new approaches and inform public health practice around the country and the world. Public health law research must be carried out with the same scientific rigor and precision as other areas of epidemiologic research and evaluation. This is important to understand its impact as a tool and improve public health outcomes. CDC's Public Health Law Program, in partnership with other parts of CDC and organizations from many different sectors, studies the relationship between law and health and promotes best practices in the application of law and policies. Today's speakers will describe the role of law in affecting the social determinants of health to protect people and improve health outcomes. Thank you.
Our first speaker today is Montrese McNeil Ransom.
Thank you, John, for that warm welcome, and thank you all for joining us today. I'm very pleased to be here to talk with you about a topic that's near and dear to my heart, public health law. I'm going to start first by providing a little bit of a historical context and provide a framework for the presentations by Matthew and Dr. DeSalvo that will follow. I'm going to begin by giving you a little bit of an overview of CDC's public health law program. Last year, our program marked 15 years for public health service. PHLP was founded in 2000 by Dr. Jeff Copeland, former CDC director, and Gene Matthews, former CDC general counsel, who saw a need for a program that would help state, tribal, local, and territorial health departments and their partners better understand the role of law in advancing their public health goals. Shortly after our founding, the September 11, 2001 terrorist attacks and the subsequent anthrax attacks took place, and there was a recognition of a broader need for public health emergency preparedness, including the need for a better understanding of public health law. During this time, and for almost a decade to follow, much of our work in the public health law program focused on helping state, tribal, local, and territorial public health practitioners better understand the role of law in preparing for and responding to public health emergencies. We worked with partners to create tools to help states in their planning for public health emergencies, including an initiative called the Community Public Health Legal Preparedness Initiative, which was the first of its kind partnership between CDC and the American Bar Association. We also began convening the first national conferences in public health law in 2002. So why public health law? From my perspective, there is no public health without the law. From the establishment of a health department, which is done by statute, to passing a clean indoor air ordinance, it really is the law that creates the framework for healthy choices to become the norm. And our legal history is rife with examples of government's action to protect the public's health. So our legal history reveals both the power and the limitations of government's authority to protect the public's health, and I'm going to provide you with a few examples. One of the more widely recognized foundational moments in the history of public health comes from the 19th century neighborhood of Soho in London. As you might recognize, this is the Broad Street pump. After several outbreaks of cholera in London, a major outbreak struck the neighborhood of Soho. John Snow, who many of us recognize as the British physician who eventually linked the outbreak to contaminated water, later called it the most terrible outbreak of cholera which ever occurred in this kingdom. In fact, the outbreak killed 616 people and caused 3/4 of Soho residents to flee. And this is often where the story ends. But it's not where the story ends. John Snow took his findings to a local council, a legal body, who then decided to remove the handle from the Broad Street pump. This is one of the very first examples we see of a legal intervention that's based on epidemiological findings. Since that time, epi and the law working together have really been the foundations for modern public health practice in this country. So let's look at an example from the United States. If you take a look here, this is Varick Street in New York City prior to New York City's sanitary reforms of the 1890s. Street cleaning and regular trash pickup were only available to those who could pay for it, to the affluent. And as you can see here, garbage and filth were allowed to accumulate on the city streets and in the alleyways, and in the rest of the city's neighborhoods, as shown in this photo. So focus, if you will, on the lamppost in the foreground. I usually have a little light that I can shine there, but focus on that lamppost. This is the same corner of Varick Street, 2 years and a massive cleanup later. It wasn't until the late 19th, early 20th century that public health reformers and public health lawyers began to see a common thread in their work, a shared understanding of the causes of disease and the ambitious sweeping action that would be required in order to protect the public's health. Along with laws and policies, sanitation laws in New York City resulted in not only improved living conditions, but a decreasing burden of infectious diseases for city residents. So I've given you an example of a legal intervention in the name of public health on the neighborhood level. On the city level, let's now turn to what we call the most important case in public health law, certainly a foundational case, and it comes from the early 20th century, Jacobson v. Massachusetts. Jacobson was a landmark Supreme Court case on the constitutionality of mandatory public health control measures. In 1902, there was a smallpox outbreak in Cambridge, Massachusetts. The defendant, Reverend Henning Jacobson, refused to be vaccinated as the law required at that time. He was fined $5, which would be roughly about $130 today, and he refused to pay it. And he challenged the constitutionality of the law in court. This case made it all the way up to the Supreme Court, where the Supreme Court affirmed the state's use of police powers to require mandatory vaccinations for smallpox. And the judges in that case, or the justices in that case, noted that there are manifold restraints to which every person is necessarily subject for the common good. Now, this case is over 100 years old, but it is still very important to public health practice today. It represented the beginning of an application of modern constitutional analysis to disease control law and to public health actions. And there were at least 4 key holdings that are important today. The first is the use of police power for public health concerns. It affirmed the state's ability to use police powers for public health. It also affirmed the ability for states to delegate certain authorities to health agencies or lower-level government subdivisions. It also provided support for actions that may limit individual liberty for well-established public health interventions. And it also provided constitutional support for a spectrum of contemporary public health laws that both Matthew and Dr. DeSalvo will expand on in just a few moments. So this has held true ever since. This table lists 4 of the 10 great public health achievements of the 20th century, originally described by CDC in the Morbidity and Mortality Weekly Report in 1999. As you can see here, none of these would have been possible without law and legal tools. So what does this mean for you? To apply law and policy to your important work in public health, it's really important that you understand the constitutional framework for public health practice in this country. The U.S. Constitution distributes power between the federal, state, and local government. We call this federalism. And it also provides a framework for the balancing of public health and individual interests. The federal government's powers come from Article 1, Section 8 of the U.S. Constitution. There's a set of enumerated powers for the federal government, and they include things like the power to tax and spend, the authority to regulate interstate commerce. But in the realm of public health, those are really limited authorities. What you'll notice is that while we have the authority on the federal level to quarantine at state lines and along our borders, the majority of core public health activities lie in the hands of the states. This power is known as the police power, and it's expressed in the 10th Amendment to the Constitution, which grants all powers that are not explicitly given to the federal government to the states. This concept of police powers is particularly important for our work in public health. It's important to note that courts generally allow state and local governments to exercise their police power as long as the action is reasonable and is for the purpose of promoting the general health and well-being of the community. And states can delegate this power or share it with their local governments. So some states give local governments extensive police powers. For example, Florida and Illinois, and California, as you see on the slide here. And others greatly limit the ability of local governments to exercise their police powers. Arkansas and Nebraska are examples of states that limit local police power. This excerpt is from the California State Constitution, which, as you can see, gives their local governments broad police powers. So what about Native American tribes? Well, tribes have a special status with their own set of powers and their ability to govern themselves to a significant extent. We call this tribal sovereignty. On tribal lands, which is known as Indian country, tribes have the power to do what's necessary to control their internal affairs and preserve their self-governance, including the ability to create their own laws and health regulations that protect the health, safety, and welfare of tribal communities. What you see here is the Navajo Reservation, which is the outer boundary, and the Hopi Tribe Reservation within it. So how can we as public health practitioners use law as a public health tool? Well, on the federal level, the federal government can use its powers to shape public health by incentivizing local action. You see this most commonly done through funding or through the establishment of a federal program that might have a trickle-down effect. The national minimum drinking age in the United States is an example of this. In 1984, Congress passed the National Minimum Drinking Age Act, which withheld 10% of federal highway funding from states that didn't maintain a minimum drinking age of 21. This law was challenged, interestingly, by the state of South Carolina in 1987, but upheld by the Supreme Court, who has said that Congress validly exercised its taxing and spending power and therefore did not infringe on states' rights. Higher level of governments can also impact public health laws and policies through a concept we call preemption, or by prohibiting action at lower levels of government. Here, it's important to note that preemption can actually be frustrating to public health activities, particularly on the local level, as we've seen with state preemption of local smoke-free laws. But otherwise, state and local governments really have a great deal of public health authority. And I'd like to close by offering you a few examples. One of the best known examples is the power of local health officials to investigate disease outbreaks and to invoke isolation and quarantine orders in order to prevent the spread of infectious disease. Another example here is while a state or local government may not generally regulate smoking in an individual's home or in single-unit housing because of the privacy interests there, it can certainly regulate smoking inside multi-unit housing. And the goal there is to protect the health of other residents from secondhand smoke. In fact, just in November of this year, a new rule, federal rule, was announced which prohibits smoking in public housing developments nationwide. The final rule prohibits lit tobacco products in the housing, in the common areas, and also in the outdoor areas within 25 feet of housing or administrative offices. Now, you won't see this ban implemented immediately. The rule does give public housing agencies across the country 18 months to implement the ban. Local governments also have considerable discretion when using zoning regulations or land use classifications. We've seen communities use their zoning laws to create farmers markets, which we know can increase access to fresh fruits and vegetables and further chronic disease prevention efforts. And police powers also allow us to protect the safety of children by requiring them to wear bicycle helmets. Interestingly, most of these laws are passed and enforced on the local level. As you can see on this slide here, there are 22 states with statewide laws, but 201 local ordinances requiring children to wear bicycle helmets. State policies can also save lives by monitoring prescription information and also increasing access to naloxone. Naloxone is the opioid medication often used to reverse the effects of narcotic drugs, pictured here in this slide. State and local laws can permit naloxone to be used by paramedics, other personnel, and even bystanders without a prescription. And finally, laws and policies equip our state, tribal, local, and territorial partners with the tools and processes necessary to effectively and appropriately prepare for and respond to public health emergencies. And a really good current example of this is the use of emergency declarations to respond to the Zika outbreak. So before I pass the mic to Matthew and then on to Karen, I'd like to close by saying there really is no public health without the law. And as you'll hear in both Matthew and in Karen's presentation, it really is the law and legal frameworks that help us to advance our public health goals in this country and help us to ensure that healthy choices are the norm. And with that, I will pass the mic to Matthew. Matthew Penn, our next speaker.
Thank you, Montrese. So the question is, where do we go from here? When you can go 3 miles in a major American city and see a 13-year difference in the average life expectancy, one place that we must go is the social determinants of health. We made incredible advances in public health across the 20th century. And if we expect to make the same advances in the 21st century, we will have to address the social determinants of health. So where does law fit in with this? Laws stand as the foundations of the systems that create social determinants of health, many of them. like healthy housing. Whether it's zoning, housing codes, improving indoor air quality, or reducing exposure to lead, law plays a critical role in maintaining healthy and affordable housing. Laws affect our transportation system with the potential to make our communities more walkable, increasing access to alternative transit like bicycles, reducing air pollution, increasing physical activity, and reducing the burden of chronic diseases generally. And education. Our education system is structured and financed through the use of law. Now, these types of laws are not important simply because they establish the systems of social determinants of health. They are important also because we create them consciously. Laws don't happen by accident. And if they can be created, they can also be studied and changed to be better. So how do we do that? Well, the first step is to recognize that law is a social determinant of health. In fact, it's one of the most significant social determinants of health. And we can study it, just like we study other issues that affect our health. We do this through transdisciplinary model of public health law, where scientists and lawyers and epidemiologists work on legal epidemiology projects, researching law as a factor in the cause, distribution, and prevention of disease and injury in populations. Public health law is not just about the law. It's about science and epidemiology and the law working together to improve the public's health. We use legal epidemiology to assess the legal environment around a public health issue, such as radiation contamination as shown on the slide here, so that we can understand trends and study impact. Legal epidemiology is the scientific study of law as a factor in the cause, distribution, and prevention of disease and injury. And legal epidemiology allows us to descriptively answer questions about what laws say and how laws work. And the practice of public health law, as I said, is transdisciplinary, involving both science and law. So what does legal epi look like? Well, whether it's legal mapping or legal evaluations, the goal is to understand what the law says, how the law changes over time, how the law relates to health data, and what the impact it's having on our health. So let's look at some examples of legal mapping and get a sense of the types of questions it can answer. So here we see an analysis of vaccine exemption laws organized by states and by regions, showing the different attributes of the laws that we assessed. So these results were pretty surprising. I think one of the things that stood out for me when we first started collecting the laws was just the sheer number. This is clearly an area very active for state legislatures. We found over 6,000 laws related to immunization and vaccines in the states. And when we started to drill down into the data, we really found that there's a wide variety in how states address vaccine exemptions, with really centering on how to obtain exemptions and the administrative requirements sort of built around those that people have to follow. Moving on to another tool of legal epidemiology, policy surveillance, legal epi can show how laws change over time. Note the deliberate similarity between the definition of public health surveillance and this description of policy surveillance. Here in this slide, we see an example of health and all policies provisions in state laws targeting those social determinants of health, with, of course, the goal being health equity in the end. We also studied state Ebola movement and monitoring policies and compared them to CDC guidance on the issue during the outbreak. The light blue represents states with policies equivalent to the CDC guidance, and the dark representing policies that were more restrictive. And importantly, we studied how they changed over time. And we noted a shift towards states clarifying their policies to be equivalent to CDC guidance. Legal evaluations are another type of legal epidemiology study. These assessments of health-related laws oftentimes come from real-world, frontline public health responses. For example, during the 2012 fungal meningitis outbreak, Public health departments needed to identify patients in hospitals and other facilities with clinical signs of the disease, figure out the cause of the disease, and then find people who may have been exposed to the contaminated steroids. One of the problems during the outbreak was getting timely and useful access to electronic health record systems. And it appeared that a variety of legal provisions both facilitated and hindered access to patient health data at a variety of these facilities. So as a result, CDC and the Association of State and Territorial Health Officials conducted an evaluation of how well state laws, and importantly, implementing those laws, allowed facilities to provide access to patient data in health departments through electronic health records. And what we found was that there were many perceived legal barriers to accessing electronic health records. That what many facilities thought were legal prohibitions to accessing the records were in fact not true barriers. Through interviews with the health departments, we identified solutions that the health departments had developed to get around these perceived barriers, both technological solutions such as dedicated health department user IDs, and also legal solutions such as new laws or memorandums of agreement worked out before an outbreak. We rolled these findings into a toolkit with ASTO so that others can improve access to electronic health records, hopefully before the next outbreak occurs. So why legal epidemiology? Why study law as a social determinant of health? I think one reason is in New Orleans, you can go 5 miles and see a 25-year difference in average life expectancy. This is the social determinants of health in action. This is legal systems affecting where we live, work, and play. And we must understand the impact that these laws have on our health if we want to change those numbers. And with that, I'll turn it over to Dr. DeSalvo. Thank you.
Thank you very much, Matthew, and thank you to the CDC and others for having me join here today. I'm happy to get the chance to share a story about the legal framework in action for public health on the front lines and how we're seeing that expand nationwide in something that we call Public Health 3.0. Matthew's correct. In a community like New Orleans, we have a gap in life expectancy, had a gap in life expectancy of 25 years based upon the neighborhood in which somebody lived, which by any of our measures would be inexcusable, but had been the case for generations. And when Hurricane Katrina struck New Orleans and the entire Gulf Coast in August of 2005, she did not bring with her the health challenges that we all began to talk about, but she brought them to light. It gave us an opportunity to understand that we had been ignoring in many ways what were not only low means but wide gaps in health outcomes for the people in our communities. The devastation from Hurricane Katrina was that the entire healthcare system, including the public health system, from 911 all the way to academic health centers and public health laboratories, was destroyed. But in that tragedy of buildings and the death of some 1,800 people, we also had an opportunity to rethink our approach to health in our community and to begin to rebuild as we put our system back together. Like many in the U.S., we turned our attention very immediately to health, knowing that the healthcare system itself was the front line, and we had not been sufficiently attending to some of the most important components of primary care and prevention. And so as we looked to change the infrastructure that we had in place, we began to consider how we would move away from a system that was very burdened by emergency room visits and hospitalizations, that most of the care for people in the community of New Orleans and the surrounding area was received in long lines in the waiting rooms of places like Charity Hospital, pictured here in this slide, a place that many of us trained and generations of people had sought out care, that was good care when you got in the system, but not available in neighborhoods and not moving upstream, certainly to primary care and prevention. The closure of Charity and many of the healthcare facilities in our community caused us to literally go on the streets and begin to meet people where they were and provide services, some urgent, such as giving IV fluids to first responders, but over time, taking over facilities and buildings in neighborhoods so that we could provide more comprehensive primary care and mental health services to those in our communities as they began to return. Really, our approach was to think about how we could get a delivery system, a healthcare system, reformed so that we could better meet the needs of the health of our population to raise the mean and eliminate the gap. We built a system that was grounded in a community health infrastructure, great primary care, mental health services, offered in these dots all in the map all across the community, serving some 20% of the population. We built up a system that was focused on improving the quality of care, the experience of care. We worked to digitize that system so that we would have individual care, not only that was better, but also be able to use that data to advance population health. And we focused on paying for value and on really expanding coverage to include everybody in the healthcare system. But as far as we took all of this healthcare improvement, better care is necessary but not sufficient to reduce a gap like you saw on the map in Matthew's presentation and in mine. We knew indeed that what we would need to do to address this kind of a health challenge would take more than healthcare. It was going to take attention to the broader determinants of health, in particular, the social determinants of health. Using John Auerbach's model, this would move us away from buckets 1 and 2, where healthcare was more engaged, to really moving towards bucket 3, where we would bring together all the potential levers at our disposal to really advance health, including the public health legal framework. It's worth just underscoring that sometimes we take the social determinants of health for granted, but in a community devastated by any disaster, in our community of New Orleans, it was obvious how important the social determinants were. People who were coming in to the healthcare system spent more time talking about their lack of housing or educational opportunities for their kids or jobs. These were the important, relevant factors in their health and on their minds every day. And so the healthcare system, but more importantly, the public health system, very rapidly began to embrace and understand that we needed to work together to address not only the medical, but all of the social determinants of health as well. We embraced this notion of public health, what we could do together as a society to ensure the conditions in which everyone could be healthy. That caused many of us, me included, to begin to look for partners in our society, our local community. And at the center of much of this was our local public health agency, buffeted intensely by Hurricane Katrina, as well as years of underfunding, but really at the cornerstone of what would be necessary to bring everyone together to improve all of the determinants of health. And I took the opportunity when asked to become the health commissioner in the city of New Orleans some 6 years after Hurricane Katrina had struck, and when we had a new mayor who was interested in rebuilding health in our community using the broad determinants. Like many other public health departments around the country at that time, we were buffeted by many pressures, including the Great Recession and significant underfunding and the loss of staffing related to that. But we also saw opportunity. You heard about John Snow earlier. There's his map on the left, and the work that he did with epidemiology, probably on paper, I'm guessing. But now we have renewed opportunities in this era from data, for example, from electronic health records. This image on the right, used in Flint to identify elevated blood lead levels in children in that community. This source of data, electronic health records, plus many other kinds of big data, is giving lots of public health departments, including ours in New Orleans, a chance at seeing the health of our communities in more real time. The first piece of advice that I got when I became a local health officer from Bobby Pestronk, who was running the National Association for City and County Health Officials, was that I needed to look at my legal underpinning and really understand what the infrastructure was that had built our health department, understand our statutory roles and responsibilities, look at where we might have gaps in our legislative or statutory authorities that might impact health, And the CDC OSTILT's team and the Public Health Law Group were right there to help us dig into where we might have opportunities or challenges and how we might build a framework for moving forward the health of our community, not only using more traditional tools, but really using what may be the most traditional tool of public health law. I say often that the framework taught me that we have to understand what we must do, what's required, that perhaps we weren't even doing, what was allowed but we hadn't yet leveraged, and what was not allowed but that we wanted to be able to do. We found in our digging, for example, that the health officer in New Orleans was allowed to regulate pigs and fowl in the French Quarter, which at first made us giggle, but then we began to realize that that could be a pretty important tool in the event of something like swine flu or bird flu, if we wanted to act quickly in our community. But we also knew that what we wanted to do was advance our policies around tobacco, since cardiovascular disease was such a major cause of death in our community. And we found, for example, that we were not actually leveraging what was expected by the state's rules. And so we had more room to grow without even changing legislation, but we knew we also wanted to and needed to do more over time. What we were doing in New Orleans of thinking about rebuilding a health department that could address the social determinants, that could use data in more innovative ways, that could bring partners to the table from various sectors to take a multi-sectoral approach, was not unique. What's been happening in local and state public health across this country is something that we call Public Health 3.0. It is a transformed way of more broadly addressing the public's health. It's what we might say is a significant upgrade in public health practice that's part of a more modern vision, emphasizing this cross-sectoral environmental policy and systems level actions that can also address the social determinants. Not to say that the work of the eras of Public Health 1.0 and 2.0 aren't critical and important, and indeed the goal is to build upon these prior eras of public health. You heard already about the importance in the early years of public health, not only of using data to understand communicable disease, but actually using policy around housing and other tools to address those social determinants to tackle the communicable disease that was the prominent epidemiology of the time. But advancing into the era of Public Health 2.0, non-communicable disease, chronic diseases became more important, and public health became more of a health care provider, particularly for marginalized populations. But this new era is a new opportunity for us to build upon those successes and again work in a more multi-sectoral fashion and have public health at the center of bringing people together to address the social determinants of health. When I came to Washington, I took the opportunity of being there to learn from other communities, to see if what we had been doing in New Orleans and what I knew of happening in other communities was a movement across the country. I wanted to understand if Public Health 3.0 could be defined and have a framework and what we could learn from successful models around the country. We laid out a framework with key components that include leadership and workforce development, secondly, essential infrastructure, particularly accreditation and accountability. Third, strategic partnerships, particularly those that may be not considered so mainstream or normal, relationships with the business community as an example. Fourth, seemed that data, analytics, and metrics were a really critical part of this new transformed public health infrastructure. And finally, flexible and sustainable funding that wasn't so categorical but allowed for blending and braiding and really more broad approaches to health. We visited 5 communities, not because they're the only ones, but because they met a set of criteria that we felt would be exemplary to help us understand whether this framework made sense and what we could do to help them stay successful and let more communities become successful. What we learned, we produced in a report this past October, which is available online at healthypeople2020.gov. We have 5 high-level recommendations that I'll walk through very quickly that relate back to that five-area framework about what we saw as successful in these communities to help them be able to transform and address the social determinants of health so that they had a broader impact. We found that they were working as chief health strategists in their communities. And this wasn't always necessarily only the public health officer, but sometimes a local business leader who was stepping up to the forefront to make sure that all the right players were at the table. Secondly, we saw recurrently that there were very structured cross-sector partnerships that allowed them to do collective action on the front lines. Third, we saw that they were accredited, that these health departments took seriously their accountability responsibilities and wanted to be able to not say themselves that they were good and strong, but that they had an external entity that was coming in and telling them and the taxpayers and their partners that they were accountable and that they were able to be strong partners not only today but into the future. Fourth, they were using data and are using data in really interesting ways. It's very actionable information that tends to be more timely and granular. They're using tools like mapping, but they're also thinking about community-level indicators beyond individual-level health indicators, such that they really are measuring and monitoring the social determinants of health. And finally, they're finding ways to expand the pie, so their funding is enhanced by creating umbrella organizations that can share funds, and that allows them to be more flexible and, frankly, to begin to work in spaces like public health law, and where they haven't traditionally had a set of categorical funding, but they understand the power and importance of broadening their reach. In fact, I'm going to show you just one statistic from New Orleans in a minute, but I will tell you that none of what we got to do, not only as an intellectual exercise as a public health commissioner, but certainly the actions that we were able to take to advance the health of our community would have been possible without public health law. It is such a critical non-medical determinant of health, but also can affect the health care system. Certainly, nationally, the Affordable Care Act has had a major impact in seeing that people have access not only to care, but to primary care and prevention. The High-Tech Act, which was part of the Stimulus Act, gave all communities in this country, not just the healthcare system, but has touched public health as well, a chance to have availability of more real-time, granular data to understand not only the care that people are receiving, but the population and the public's health. And we took that even further in our community in New Orleans, looking at how we could tackle the leading causes of morbidity and mortality, particularly cardiovascular disease in our community. And through our umbrella efforts of our social determinants of health and public health 3.0 work called FitNOLA, we advanced policies through our city council like Complete Streets to increase the opportunities for physical activity. And eventually, the community of New Orleans went beyond what was on the books as a smoking policy and went for a citywide smoking ban. And what you're saying is the same thing that U.S. News and World Report said. Really? New Orleans? We, as the communications people will tell you, get the headline and the picture, and we did. We were so proud as a community to be recognized for our culture of health and our roadmap that we had laid out forward. It's a community that historically may not have been known for health, but we understood very quickly that only by working together and including the broadest tools and levers at our disposal would we be able to advance the health of our community. And though we don't have gap data quite yet, this information from county health rankings is but one of many indicators that you are welcome to look at about how we have been progressing in health in the community of New Orleans. And certainly premature death is down, as are many healthcare indicators and increasingly some broader public health indicators like physical activity. New Orleans is an example of one community that has learned to build upon the strong foundations of public health in the eras of 1.0 and 2.0 and begin to address broader social determinants. The work that we have done to advance in that community, just as we have seen in communities all across the country that are public health 3.0 style communities, is grounded in the importance of public health law, not only how they're statutorily created, but how they use that as a tool to advance the public's health. Thank you all very much.
Thank you. Thank you, Matthew and Dr. DeSalvo. It's now time for Q&A. A couple of quick notes. You'll need to ask your questions via the microphones that are in the middle of the room back there. And also, it's very important that we keep the questions brief. We want to try to fit in as many as we can in the remaining time that we have. I think I should start first with Susan. Do we have any questions from our online participants?
We do, thank you. Can the power to regulate interstate commerce be used to regulate food industries for maximum health outcomes, for example, sugar tax?
So I will turn that one to Matthew. The question for those who weren't able to hear that was, can the federal government regulate food products like sugar-sweetened beverages using the interstate commerce?
Federal law is currently used to regulate food products, so I think the answer to that would be yes. Remains to be seen whether or not anyone at the federal level would move to regulate sugar-sweetened beverages, but clearly the authorities there to regulate food as it crosses state lines and is a national industry.
Thank you, Matthew. I think we can go ahead and take questions from the room. If you've got a question for our panelists, please step to the mics in the middle of the room there, please. Oh. Having seen no one move, Susan?
Would you ask the presenters in today's grand rounds to address how public health is affected by housing laws?
It's a good question. I think we touched on that some during our presentations, but I will open the mic for Karen to answer that question first. And the question is, how do public health laws impact housing laws?
It's a great and important question because it's worth noting something that Montrese spoke about in her presentation, which is the foundations of public health actually really date back to a time when the public health infrastructure leveraged the built environment, including housing policy, to tackle a whole host of scourges, including infectious diseases like tuberculosis. And some of the most effective tools that we have had that have reduced the transmission of tuberculosis, as an example, have been housing spacing and housing policy up through today, when we are increasingly understanding that secondhand smoke has a significant negative impact on the health of children and others. And so in this space, the Housing and Urban Development made a movement to prohibit exposure to secondhand smoke in housing. And there's a really one other component that's worth saying, which is we often think about sort of health as the outcome, and it is, but if you just think about the most important overall determinants of health and well-being, housing is the most important. So quality housing in and of itself has a dramatic impact on people's health, much less the policy that we apply in the housing setting.
Matthew, would you like to add to that?
Yeah, I think a good context to put this answer in is sort of listening back to something that Dr. Frieden said, and law really affects everything that surrounds us, including the houses that we live in and the apartments that we live in and the places we rent and even the commercial buildings that we go into. So it really has to do with where your house is located in relationship to other things that may be detrimental to your health. When you walk into a house, that house was built with a permit, and that permit was approved under building codes. And the purpose of those building codes is to keep people safe and to protect the public's health. Even the things in your home that surround you, your appliances, your fixtures, all of those things are regulated with an eye towards keeping people safe. The paint that we use, the products that come into our homes, all of these are regulated with safety in mind. And the idea is to reduce morbidity and mortality in the places that we live and the places that we go and shop, if you talk about commercial buildings as well.
Just a follow-on to that, which is one of the differences in more recent years is that the notion of the impact of say, housing on health is a bit of an afterthought at the table and isn't always present in the conceptualization phase. So we might call this health and all policies approach, where in a community it would be expected that public health leadership would be at the table to help think about the intended or unintended consequences, whether that's in housing policy or transportation policy. And these Public Health 3.0 communities, one of the movements we're seeing is that public health is at the table and sometimes leading at the table, such that they're more involved earlier and not trying to then subsequently change policy after it's happened. And again, mirroring some of the earlier years of public health, when public health was such a strong leader in communities and was at the table helping to shape policy like transportation, housing. I think it's increasingly important that we do this so that we're weaving it into the fabric of all the policy decisions we're making at the local and the state and federal level.
Thank you. Thank you both. Do we have additional questions from online participants, Susan?
We do, and I would encourage our online audiences to pose their questions at Twitter, Facebook, or to grandrounds@cdc.gov. This next question has some multiple parts. How can CDC do the greatest amount of good for our nation's health with regards to chronic disease? And I'll kind of break it into parts.
So the question is, how can CDC have the greatest impact in the area of chronic disease? And I'm assuming end the law. Matthew, thoughts? Karen, who wants to go
CDC
first?
answer that one.
All right, Matthew.
Is there another part of CDC that wants to answer that? I think CDC is doing it. We're active in this space. I mean, I think the thing we try to do in public health is identify interventions that work. And I think public health law and policy come in where we want to have those, where interventions are proven to be effective, and there's a desire both socially and politically to have those interventions apply to broader populations. And I think CDC is active in this space. If you look at something like the Winnable Battles Initiative started under Dr. Frieden, clearly there's an emphasis on chronic disease. Non-communicable diseases are the biggest killer in the United States, and CDC has been very active in addressing those over this past administration.
But I'll answer for HHS, which is Health and Human Services, and which is simply to remind people that there is a pretty broad umbrella of opportunity, not only at HHS, but federally, to address the public's health. And we're, again, remembering these things increasingly. So whether that's in housing or transportation as examples, but even closer to home, the Food and Drug Administration, which in recent years has banned trans fats. And if you think about cardiovascular disease as a leading cause of death, the impact that has not only on an individual, but at a population level. And we're certainly trying to use every tool in our toolbox to advance the health of the public.
Thank you. It looks like we have a question from someone in the audience. We'll start over here. Judy?
Hi, I'm Judy Lipschutz from Ostels. Thanks for a really great presentation. I think it's really important and great to hear this presented at CDC from all of you. I wonder if you could speak to some terminology issues, because a lot of the social determinants of health work is also talking about structural determinants of health, and things like civil rights issues, civil rights laws, discrimination laws, anti-discrimination laws. How would you see those as interplaying in this world that you're talking about of social determinants of health? Would you call them structural? Are there these kinds of issues being discussed in the Public Health 3.0 communities?
Karen, do you want to take that on?
Well, I love this question. Do we have about 4 hours that we could dig into it? It's quite relevant for a number of reasons. One is the language social determinants, I think, begs to be improved because it doesn't, as you say, quite capture either the broadest umbrella of all of the many determinants of health, and it can be so nebulous that it's hard for people to know how to act. I would want to commend the CDC specifically in that second area and their work on this, the High Five, the High Impact in 5 years, which are sort of specific toolkits that can be used to address the social determinants. And those social determinants are defined through the federal space by Healthy People 2020. There is actually a structured definition that we've all agreed on. But when you step out of the bounds of what we do here in government and begin speaking to leaders in business or local elected officials, I think that language gets to be a little more confusing. So there is work to be done to clarify it. I also want to just step on something you said. I haven't used this language, structural determinant of health. We did talk a lot about institutional racism in New Orleans. It was a major part of the public health conversation that we had there, and that would be a sort of a structural determinant of health. I think where we made a lot of progress in health generally in the last 8 years of this administration is in civil rights progress globally, and I think that stands to help advance health more broadly. We don't often think of civil rights as a social determinant more broadly. So I'm glad that you raise it because we shouldn't lose sight of that. And but here's what we should do: we should find a way that public health isn't talking to itself, and that we're expanding this conversation because I can tell you that payers and business leaders and elected officials and civic leaders and communities are hungry to really understand what this other questioner asked, which is how can we make the most difference on what's killing people in our country and killing them at a rate that is increasingly alarming, because we're losing the battle for the public's health. And so we shouldn't let the language get in the way of at least us beginning to have that broader conversation.
Yeah, it's a great question. I think about it in kind of in two different ways. I think on the one hand, clearly structural racism, systemic racism in the United States is a social determinant of health, clearly. I think the exercising of civil rights is also a social determinant of health. I kind of put civil rights laws in a little bit of a different category, because I think they stand as a tool that we can use to address the exercising of civil rights and systemic racism. So I think they kind of counterbalance each other, and certainly something that we study within the public health law program quite in depth. And the development of new civil rights laws, for instance, under the Affordable Care Act in Section 1557, is a way to move the ball forward on civil rights and start to address some of the health disparities and racial disparities that we see in the country. So it's an emerging area of study, I think, across the country, including here at CDC.
And I'll just say in my studies, in earning an MPH and studying the social determinants of health, that language structural determinants was used. For me, what the work that we're doing really unpacks that a little bit. How are the structures developed? What legal processes and tools are we consistently using in this country to sort of establish those structures? And are those structures barriers or impediments to health, or where can they actually be levers toward improving public health? So to me, it's more of an unpacking of that term, and making sure that all the people at the table the people that have a role in that are at the table for those discussions. I think we had a question over here. There was a man sitting down with his hand up. Yes, sir, that's you.
Yeah, I just was wondering if you could address the Affordable Care Act a little bit more in its role in public health, and what aspects of it do you feel are most needed, given what we anticipate is the repeal of that law. Usually you don't hear about that law being a public health law. You usually hear about it as, how we pay for medical care and how that's organized. But you're talking about it in terms of the Public Health 3.0, and that aspect probably has not been addressed as well.
I think that one's for you, Karen.
Yeah, to begin, I would just share that the Affordable Care Act was a law that had broad reach beyond just paying for care, and as some people may know, it touched on civil rights issues. It created a prevention fund. It created some infrastructures that are directly public health related to support better thinking and better advancement of public health goals. It helps to advance the availability of data and information, not as directly as high tech, but has some touches on it. I think where it had more impact on the public health infrastructure was in reducing the number of uninsured. I must say by 20 million more people being insured and having the lowest rate of uninsurance in this country ever since we've been measuring it, below 9% now. And what that felt like for public health departments was that people who had been receiving care in public health clinics who were uninsured, I was one of them as a child, have now a way to pay for their care and can go anywhere. And that has meant that for public health, they've been able in some cases to get out of the business of delivering direct services. And anyone who's run direct service delivery knows it can be very time consuming. You're really focused on an individual rather than on a population. So it's created some bandwidth for policy thinking that has brought public health forward, but also I think to some roots. And that movement has not been without tension and without struggle, but many public health departments have embraced it. We certainly did in New Orleans, and others have, and it's given them the opportunity to be a neutral convener, so they're not a healthcare provider in the community, and they can bring others to the table. It's meant a loss of revenue, so there's been some downside. I don't want to minimize it. Whether the Affordable Care Act, then, if there's going to be a change, we haven't seen legislation, but if, let's say, coverage were to go away for those 20 million people, then that would probably change the role of public health in communities again. And I amongst the many reasons that I wouldn't want to see people lose access to quality care is that I think public health is accountable to everyone who lives, learns, works, and plays in your community every day. Like, there's nobody else like that. You don't have anybody else who's making sure that you're alive today, because that's what's required in law. And having them focus on other books of business, because there's no one to backfill that, the safe water, all the things that we all know and believe and talk about, I believe is going to step us back as a country in our health. So good specific things, but I think more broadly it's been to help them move back in the stronger space of broad public health.
Okay, we are coming up on time. Susan?
One more question.
One more question.
We have several, but all of them will be answered via email later. Are laws being brought to Congress that would increase federal jurisdiction in case of a healthcare disaster or outbreak?
What was the first part? Our laws?
Are laws being contemplated that would further, on the federal level, that would further protect us in a public health emergency?
I am not aware currently of any laws being introduced to Congress right now. That we've had some preparedness laws passed over the years, certainly at the federal level. Some of them updated, reauthorized, but nothing currently on the slate, as it were.
Before we get the hook, I have to do a commercial for Matthew and his team, and I want to publicly say thank you to him and to his team for helping not only the New Orleans Health Department, but health departments all across the country. And not that I want to lend you out, but I think what you've been doing here is, in the last few years especially, is reshaping our thinking about the power and importance of public health law and creating a field of public health epidemiology that's going to lead to some measurement, that's going to allow us to have a much better feedback loop as we begin to assess the social determinants of health. So I thank you, and I thank the CDC for bringing this to the forefront in public health.
Thank you.
Well, I'd like to again thank all of our presenters. Again, there will be additional content, videos posted online so that we can all continue the conversation and continue our learning. Please join us next month for CDC Public Health Grand Rounds. Thank you.